Dental implants function through a microscopic biological process, or a titanium post to act as a tooth root. Living bone tissue must physically grow into and weave around the textured metal surface. The International Team for Implantology defines three loading protocols based on the time to restoration. Immediate loading happens within 1 week of placement. Early loading follows between 1 and 8 weeks. Conventional loading wait times exceed 2 months. To evaluate if these accelerated protocols compromise clinical outcomes, Dr. Monica Pigazzo led a systematic review and meta-analysis, specifically tracking single crown survival rates. Looking at survival data for both 1 and 3 years, the meta-analysis found a risk difference of exactly zero. Statistically, the risk of failure is identical whether crown is attached on the day of surgery or 2 months later. This creates a clinical paradox. Osseointegration is a protracted biological journey, yet an immediately loaded implant is placed into full function on day zero, supported entirely by mechanical friction. Because macro level outcomes match so perfectly, survival rates alone cannot explain why individual cases will fail. To identify the hidden variables behind early failure, we have to look past the survival statistics and into site biology. Surgeons often treat high insertion torque as a guarantee of success. If the implant fails tight during initial osteotomy, it is assumed to be safe for immediate loading. That initial tightness is primary stability, a purely mechanical hold. Secondary stability is different. It is the biological result of new bone formation. Clinical attention is frequently skewed towards this first stage. Surgeons prioritize achieving high mechanical friction against the native bone during surgical procedure, but mechanical friction is temporary. As the bone begins to heal, it remodels and the implant must transition from mechanical hold to a biological one. This handoff is the most vulnerable moment in the implant's lifespan. High initial stability creates an illusion of security. It provides a solid mechanical baseline that can mask biological vulnerabilities, leading to unexpected failures if the handoff to new bone growth is interrupted. In the weeks following surgery, every implant undergoes a predictable physiological decline known as stability dip. This maps total stability over 10 weeks. As osteoclasts resorb bone around the threads, primary mechanical stability actively degrades. Meanwhile, the secondary stability rises as new bone forms, but with a slower onset. The intersection creates a V-shaped gap. The stability dip. During this period, the total stability of the implant drops significantly below the level achieved at the time of placement. An immediate loading protocol places a crown into function exactly when implant is at its weakest point. Surviving this first month requires a strategy to manage this physiological deficit rather than simply relying on day zero friction. We can quantify this transition using Simunec clinical data which tracked implant stability quotient or ISQ over 10 weeks. For implants with high primary stability over 72 ISQ, findings are counterintuitive. Their stability trends downwards for the entire first month. Conversely, implants with lower stability gain stability over that same time frame. By week 5, all groups converge. The steepest drop for those high torque implants happens explicitly between week 1 and week 4. Advanced surface technologies such as alkali treated or hydrophilic modifications are designed to alter this trajectory. These active surfaces accelerate early bone to implant contact by shifting the biological stability curve to the left. They reduce the overall depth of the stability dip. These initial ISQ matrices are temporary mechanical placeholders. This tissue acts as biological barrier, physically separating the titanium surface from viable bone cells. This prevents the stabilization of the initial blood clot. Without a stable bridge, the healing mechanism defaults to forming a fibrous capsule, completely isolating the implant. In a thoroughly degranulated site, there is no barrier. Osteoblasts are free to migrate and begin ossification process. If fibrous capsule occurs, implants will become mobile regardless of its primary stability. Biological cleansing is the absolute prerequisite for osseointegration. High mechanical torque cannot compensate for contaminated surgical field. Spear education framework evaluates the implant site suitability across 4 key quadrants: aesthetics, function, structure, and biology. Consider this case of an immediate load single crown in the anterior maxilla. The surgeon achieved good primary stability but overlooked critical risks. The patient had a thin tissue biotype and deep vertical overlap, subjecting the healing site to excessive functional stress. At 3 weeks post placement, implant became mobile and had to be removed. The timing of this failure matches the stability data perfectly. The implant was lost at the exact trough of the stability dip. Mechanical stability degraded as expected, but the combination of compromised biology and functional overload prevented the development of secondary biological stability. Clinical failures during immediate loading occur precisely when the physiological stability trough intersects the unmanaged biological or functional stress. Joint consensus guidelines from the Academy of Osseointegration, the AAP, and the ITI provide a roadmap for these decisions. These organizations recognize that immediate and early loading are highly predictable, safe options for majority of the patients. However, these accelerated protocols require specific conditions: pristine site biology, adequate bone volume, and thorough degranulation. Clinicians must identify variables that threaten this balance, such as parafunction or a thin tissue biotype. When these risk factors compound, clinicians must follow the rule of the protocol retreat, reverting to conventional loading schedule of over 2 months. Successful accelerated loading relies on an accurate prediction of the biological stability timeline and surgical discipline to respect the site's objective limitations.